The topic of our today's lecture is examination of the patients with kidney diseases. First of all, I want to remember you that in our organism, two kidneys are present. From anatomy, you know, both kidney localized on the level of lumbar region and right kidney position slightly lower than left. Main functions of the kidney is filtration of the blood with formation of urine, with which toxic substances will remove from our organism. Depending urination, kidney regulates in our organism water mineral balance. Kidney control blood pressure and first of all diastolic blood pressure due to activity renin-angiotensin system which produced by the kidney. Kidney take part in hematopoiesis due to synthesis of erythropoietin. Main units of kidney is nephron, which activity control functional ability of kidney. During today's lecture, we will stop on main kidney pathology. First of all, pyelonephritis. It's bacterial inflammatory process into the kidney, and if it is bacterial process, may be affected only one kidney. Other kidney can hold its functional ability. Glomerulonephritis. It's a specific immune-dependent inflammatory process when first of all affected glomeruli. As a result will be disturbed filtrative function of kidney. Glomerulonephritis, on contrary from pyelonephritis, affects both kidneys simultaneously, and you understand as any immune pathology it is more heavy process in which kidney insufficiency or otherwise disturbed functional activity of the kidney appears early. Nephrolithiasis, metabolic disorders in which into the kidney will be formed stone. Maybe one stone, maybe more than one stone with different structures. We will know about nephrolithiasis in case when the stone obstruct urinary tract and manifested with specific clinical picture of renal colic. Amyloidosis, pathological process which appears as a complication of any primary pathology with involvement protein metabolism in pathological process. Because amyloidosis is characterized with formation pathological protein amyloid, which hold inside the organs, first of all into the kidney, and disturbed their function due to disordered structure. And canceromatous process. New growths can affect any organs and kidney also. Now, if you are oriented in main pathology of the kidney, we will examine patients with diseases of kidney depending of plan. And first of all, we'll distinguish main clinical symptoms which may be revealed of the patient with kidney diseases. There are painful, diuretic, edematous, hypertensive, inflammatory and intoxication symptoms. We'll start from characteristic of pain. And I'll pay you attention depending on anatomic position, pain localizes in the lumbar region. Burning pain in the urethra during or after urination indicates about inflammation of urethra, urethritis. Suprapubic pain tightly connected with urination indicates inflammation of urinary bladder, cystitis. And some problems of the patient during urination, difficult or painful urination, is called stranguria, which is characteristic for affection of lower urinary tract, urethra, or urinary bladder. And I want that you remember this problem are not characteristic for the kidney pathology. Affection of kidney manifested with pain in lumbar region. We know location of pain, and I said you that we have two kidneys which may be activated simultaneously or separately. As a result, pain may be unilateral or bilateral. But I'll again pay your attention. Position of the pain lumbar region, nearest level of the 12th rib. Pain irradiates downward along course of urinary tract and in inner surface of hips. If affected right kidney, it must be differentiated with pathology of liver. But if you remember last lecture, liver pain irradiates upward. Kidney pain irradiates downward along course of urinary tract. Unilateral pain, which indicates affection of one kidney, is characteristic for pyelonephritis, I said you, which is bacterial affection of kidney which can involve only one kidney in pathological process. Unilateral pain is characteristic for paranephritis, inflammation extrarenal cellular tissue when pathological process spread outside. Unilateral pain is characteristic for renal infarction pathology which appears due to obstruction of the renal artery and nephrolithiasis, because rare case renal colic will be bilateral, because rare case both stone start its movement simultaneously. More often, pain unilateral. Bilateral pain indicates about affection both kidneys simultaneously. It may be in pyelonephritis. It is characteristic for glomerular nephritis and for heart decompensation. Other word, final stage of the heart failure, when the blood congested in greater circulation, and we are talking about congestive kidney. For kidney, more characteristic dull and boring pain, because kidney is parenchymatous organs and patient feels pain due to distension its capsule. And pain more often is characteristic for patient with pyelonephritis, especially chronic pyelonephritis. It may be in acute glomerulonephritis and less frequently for chronic glomerulonephritis. Glomerulonephritis usually isn't manifested with pain, about which we'll say later. Congestive kidney Result of heart decompensation, also characterized with dull and boring pain. Sharp, sudden developed pain is characteristic for renal infarction, and sharp pain which appears as attack is called renal colic, which is characteristic for obstruction of the urinary tract with stone, true renal colic due to nephrolithiasis, and sometimes it must be differentiated with movable kidney. When the kidney, due to weakness of ligamentum, easy moves from in downward, urinary tract bending, and due to bending of ureter and obstruction of urinary tract, patient sometimes can feel severe piercing pain which resembles renal colic. But on contrary from renal colic, pain in movable kidney may be released due to change in position because kidney come back in initial position, urinary tract again becomes straight, obstruction removed, and pain disappears, which cannot be used for releasing renal colic. Pain in renal colic, more often unilateral, it appears as attacks, increases periodically, and then subsides on some time. It irradiates downward along course of ureter into the perineal region to the urinary bladder and urethra. It can be provoked by taking much liquid or jolting motion, other word actions, which promote movements of the stool, which obstruct urinary tract and manifested with severe spastic pain. Pain may be released with spasmolytic medicines, with atropine sulfate. In home, it may be released with hot water bottle or warm bath, because you remember that warm procedure relax smooth muscles, and sometimes ureter may be dilated and small stones can pass downward, obstruction release, pain disappears. And again, I'll remember you, in movable kidney, pain may be released with changing posture, which helps come back kidney in its initial position. Diuretic symptom, next problem which appears of the patient with kidney diseases. Dysuria, disordered urination. Any problems with urination included in diuretic symptoms. Dysuria, deranged urination. To give characteristic of diuretic symptoms, first of all, we must understand what is diuresis. Diuresis is secretion of the urine during a certain period of time. We distinguish daily diuresis when we'll count amount of urine during daily period. Night diuresis, maybe 1 hour, 3 hours diuresis, maybe whole day diuresis. When we are talking about diuresis, it's obligatory, must be compared with intake liquid, and depending correlation between intake liquid and amount of excreted urine, we are talking about negative or positive diuresis. Negative diuresis, when the amount of urine significantly less than intake liquid. Normally, will excrete 70% of intake liquid. For example, if the patient takes 1 liter of water with urine, will be excreted nearly 700 milliliters. If less, we are talking about negative diuresis. It indicates that liquid holds inside the body and we must find edema. Or negative diuresis may be result if the liquid will be removed with other way. For example, severe sweating, if the patient long time be in the dry room. It is characteristic for the period of hot weather. It may be result of repeated vomiting or profuse diarrhea. Positive diuresis, opposite correlation. Amount of urine exceed intake liquid. It may be if the patient take diuretic medicines. Other words, it is characteristic for the period resolution of edema, and if we'll prescribe diuretic medicines, amount of urine must be more than intake liquid. We are talking about positive diuresis, which indicates about effect of our treatment. Normally, daily diuresis varied from 1.5 to 2 liters of urine because usually we'll intake nearly 2 liters of water. If the amount of urine more than 2 liters, we are talking about polyuria, which may be physiological or pathological. Pathological polyuria, other words polyuria of renal etiology, indicates about renal insufficiency. And first of all, we'll find problem in secondary, formation of secondary urine because problem with reabsorptive process. Extrarenal etiology or physiological functional polyuria is characteristic for the patients who take much of liquid because if we'll intake more than 2 liters of water, will excrete also more than 2 liters of water. It is characteristic for resolution of edema after taking diuretic medicines, and it is first symptom of diabetes mellitus. Opposite problem, amount of urine decreases. And when the amount of excreted urine becomes less than half liter, I'll pay your attention, not less than intake liquid. Less than half liter, 500 milliliters. We are talking about oliguria, which also may be renal and extrarenal etiology. Renal etiology of oliguria is result of renal insufficiency. Problem in primary filtration of urine. We'll find problem in glomeruli. Extrarenal etiology is characteristic for the people with limited intake liquid. When the liquid will be removed with other way, with severe sweating, with vomiting or diarrhea, or it may be characteristic for final stage of heart failure, decompensated cardiac patient, when the peripheral circulation such significantly disturbed that filtration of urine progressively decreases. Next problem, anuria. We are talking about anuria when the secretion and excretion of the urine stop. We'll start to talk about anuria when the amount of excreted urine becomes less than 50 milliliters. 50 milliliters. Anuria, depending its origin, may be secretory and excretory. Secretory anuria appears due to severe problem with glomeruli. It is characteristic for acute glomerulonephritis. It is result of progressive nephrosclerosis when the active units of kidney progressively decreases due to pathological growth of connective tissue. Secretory anuria appears as acute situation of the patient with poisoning with sublimate or other nephrotoxic substances. It may be complication after transfusion of incompatible blood due to obstruction of arteries with destroyed erythrocytes. It may be a result of progressive heart failure, shock, because shock is characterized with significant decrease of blood pressure. You know, blood pressure is main regulatory mechanism of the urine secretion. And profuse bleeding, because no blood, no adequate filtration. Excretory anuria is characterized with impossible evacuation of the urine from kidney into the urinary bladder. Other word, obstruction of ureters by calculus. It's a rare case when the both ureters obstructed simultaneously, because you know, if only one kidney arrests, other kidney completely can compensate its function. It may be result of inflammatory edema of the mucosa of ureters and proliferation of malignant tumor, which compress ureters and obstruct passage of urine. Excretory or renal anuria may be a result of refractory process due to severe pain, usually due to contusion or fractures of the extremities. But it disappears after taking severe analgesic medicines. Anuria is absence urination, which have two origins: secretory, kidney problem, or excretory, ureters problems. Anuria must be distinguished from ischuria, because both problems characterized with absent urination, but different level. Ischuria is characterized with obstruction lower urinary tract when the urine cannot be evacuated from urinary bladder due to affection of spinal cord, which is characteristic for obstruction of urinary bladder or urethra with calculus, or outside obstruction due to problem with adenoma, and it may be result of the new growth into the urinary bladder tumor. Ischemia may be result of unconscious condition. And you understand why oftenly patient in reanimatological or emergency aid department must be catheterized because unconscious patient cannot regulate process of urination. Again, secretory anuria, problem with kidney through affection of glomeruli. Excretory anuria, problem with evacuation of urine from kidney into the urinary bladder, affection of urethra. And ischemia, which is obstruction of lower urinary tract. Urine cannot be evacuated from urinary bladder. How can we distinguish this process clinically? Patient enters with primary diseases, acute retention of urine when he hasn't urination during 24 hours. In admission department, we'll see patient with primary disease, acute urine retention. Then we must decide what is cause of this problem. We'll do differential diagnosis between anuria and ischemia. And more easy manipulation, which is catheterization of urinary bladder. If the urine removed through the catheter, our disease will be ischemia. We'll hospitalize patient in urological department and find problem in lower urinary tract. No urine in urinary bladder. We are talking about anuria and continue our differential diagnosis because we must decide it's secretory or excretory anuria. With this purpose, we'll send our patient on X-ray examination. We'll introduce specific contrast medicines and then send the patient on X-ray examination. And if we see kidney, it shows that contrast go through the glomeruli and kidney structure, kidney pelvis becomes visible. It indicates about excretory anuria and will find any obstruction on the way of urethra. If the kidney unvisible, it shows that contrast cannot go through the glomeruli. We are talking about true pathology of kidney, secretory anuria. Other problem with urination, it's time. Normally, we'll urinate from 4 to 7 times per day, depending on water regimen. If patient urinate oftenly, we are talking about placiuria, more than 7 times per day. Placiuria may be characteristic for the patient which intakes much liquid or in getting cold. Sometimes I think you feel this problem when you overcooled or when you intake much of liquid. Placiuria is characteristic for affection of lower urinary tract due to irritation of urinary bladder or urethra. we are talking about cystitis or urethritis. Frequency of urination may be decreased. Usually, it is accompanied with oliguria, because you see it is characteristic when the patient intake limited liquid after eating much salt food, when the liquid holds inside the body, or as a result excessive sweating, vomiting, diarrhea, or in fever. Iduria, next diuretic problem. We are talking about iduria when the patient urinates about equal intervals with about equal portions of urine. But you understand, more objectively, we can say about iduria during specific examination, Zimnitsky test, when the patient collects urine in special container and we can measure its amount. Iduria is result renal insufficiency because normal kidney control amount of urine which tightly correlated with intake liquid. When the process control of urination disturbed, we are talking about renal insufficiency or renal failure. Next problem is nocturia. Objectively, we are talking about nocturia when the amount of night urine exceeds amount of daily urination, and objectively it can be assessed only with Zimnitsky test. Subjectively, patient can say about nocturia when he gets up for urination 2, 3 or more times per night, and it's not correlated with intake liquid. Nocturia may be two origin, cardiac or renal. Cardiac nocturia is characterized with daily oliguria, amount of daily urine less than 500 milliliters, but nocturnal urination significantly exceed daily urine. It helps you understand why cardiac edema intensifies to the evening and disappears in morning. Because when the all other organs relax, active blood circulation is enough for activation of kidney activity and active, as a result, active filtration of urine. Renal nocturia is characterized with daily polyuria, and it indicates about renal failure. Other problem which is connected with dysuria is change of the urine color. Patient can see that urine instead light yellow becomes red color. No, everybody knows the red color first of all associated with bleeding, and it may be a result of hematuria, which is characteristic for glomerulonephritis, attacks of renal colic, or new growth. But it's obligatory must be examined with laboratory method, because only color not indicate about hematuria. It may be result taking some food or some medicines. Urine can be brown color. Foamy brown urine is characteristic for jaundice, especially hepatic and obstructive jaundice due to increased bound bilirubin in blood, which water soluble and easy removed through the kidney. In any pathology, urine lost transparent and becomes cloudiness. It may be result of some pathological elements in urine, leukocytes, protein, and any other substances which may be cleansed only with laboratory method. Next problem, edema, which is characteristic for acute and chronic renal diseases and tightly correlated with diuresis. We remember negative diuresis manifested with edema. We said about edema, which was characteristic for heart diseases. And when the patient complains of edema, first of all, we must differentiate between cardiac and renal origin. It is possible due to location. Heart edema starts from lower extremity, from the leg. Renal edema from the face. First of all, edema localizes near the eye. We see eyelid edema. Cardiac edema intensified to the evening. Renal edema to the morning. Cardiac edema concord with bluish color of skin, cyanosis. Renal edema with pale color of skin. Cardiac edema is elastic during touching. Renal edema is more soft. Now, this characteristic helps you differentiate cardiac and renal edema. Hypertensive symptom. I said your kidney take part in regulation of blood pressure due to renin-angiotensin system activity. Hypertensive syndrome, first of all, is characteristic for the patient with glomerulonephritis, for nephrosclerosis. Later, it appears of the patient with nephrolithasis and chronic pyelonephritis. Hypertensive symptom clinically hasn't any specific characteristic. Patient feels headache, dizziness. It can accompany it with heart pain, which is characteristic for any origin hypertension. But in renal hypertension, early than in other types of hypertension, is characteristic deranged vision, neuroretinitis, because kidney regulate diastolic blood pressure, which depends from tension or resistance of peripheral vessels. And if diastolic pressure increases, peripheral vessels significantly constricted. You understand? Our central nervous system and our vision highly sensitive to blood circulation. And as a result, deficiency of blood flow will be early affection of vision, neuroretinitis. And I'll again pay your attention. If you measure pressure of the patient with headache, dizziness, and reveal high diastolic pressure, more significantly increased as systolic, first of all, we must exclude pathology of the kidney because it is characteristic for renal hypertension. No, for example, you see both pressure increase, but high diastolic pressure is characteristic for renal hypertension. Inflammatory symptom manifested with fever, chronic pyelonephritis is characteristic with subfebrile fever. In acute pyelonephritis, in paranephritis, fever may be higher for febrile or other level. Bacterial infectious process always characterized with high temperature. And when the patient has loin pain and fever, first of all, we think about pyelonephritis. Then maybe involved urinary ducts, urethritis and pathological process. If the process spread outside, we are talking about paranephritis. All these pathological processes due to bacterial origin characteristic with fever. Intoxication appears as result renal dysfunction or renal failure, because if you remember, I started our lectures from characteristic of main renal function, and first of all, it's detoxicated function, because with urine from our organism will remove all toxic substances. If this process disturbs, toxic substances hold inside the body. Patient feels weakness, indisposition, problem with central nervous system as impaired memory, deranged sleep, as a result decreased work capacity. Later, from the patient will be specific unpleasant odor due to hold of urea into the body, and if it cannot be removed with urine, it becomes removed through the kidney, through the skin, through the mucus. Patient complains of skin itching due to involvement of all organs membrane. Will be dyspeptic disorders, will be problems with cardiovascular system, and clinical manifestation of any intoxication, which is nausea and vomiting, after which patient doesn't feel better condition, which help differentiate from vomiting stomach origin. We remember that stomach vomiting accompanied with a good condition. Central intoxication vomiting whenever helps a patient. All these symptoms indicates about renal failure and retention in the body, first of all, protein decomposition substances, creatinine, urea, nitrogen. Next step of our examination is inspection. And again, we'll come back to our first lecture. And remember that kidney is vital organs. If it's vital organs, it regulates general condition of the patient. Due to intoxication, will be disturbed consciousness of the patient. Due to decreased vital activity, will be changed posture in the bed. We can see convulsion. Skin of the patient with kidney disease is rich with pathological symptoms. We'll find edema. We'll obligatory exam done of the patient and finish with local inspection, anatomic position of kidney, lumbar region. If we are talking about condition of patient, it's progressively disturbed from moderate to grave in final stage of the renal failure. Synchronously will be changed patient consciousness from the irritative disorders to uremic coma. If we are talking about posture of the patient in bed, in grave condition and unconscious patient, we are talking about passive posture. But we distinguish all these pathological indices characteristic for final stage of renal insufficiency. We distinguished first posture, which regulated any pathological process. And we can see patient which predilected to position on affected side with the flexed leg, bringing the knee to the abdomen. Such posture is characteristic for the patient with paranephritis. Other first posture where the patient restless, he tosses in bed, groans or even cries from the pain. Find any position which helps release pain. Such first posture is characteristic for the patient with renal colic, with nephrolithiasis, or may be characteristic for movable kidney, but after some time, definite position helps relieve pain. You see patient with renal colic and patient with paranephritis. Skin of the patient also rich with visible signs. Sometimes we can see convulsion. It appears of the patient with uremic coma due to disordered mineral metabolism. It may be a result of renal eclampsia, about which we'll talk later. And sometimes it may be a result of pregnancy nephropathy. As disbalance of microelement. Edema, first of all, localizes on the face. I'll remember, it is first of all early appearance of the patient with glomerulonephritis, maybe patient with pyelonephritis. It is specific signs of nephrotic syndrome and amyloidosis. You see edema which localizes on the face first of all, then it spreads along entire body on lower extremities, and any sides of body will press and see formation of fossa as a result of edema. And due to specific edematous phase, we distinguish specific phase appearance, facies nephritica, which is more characteristic for the patient with glomerulonephritis and nephrotic syndrome. You see, patient cannot open the eyes because severe edema. Skin of the patient. No, first of all, we'll pay attention on its color. For kidney is characteristic pale white color of skin due to narrowing or spasm of skin arterioles and as a result of anemia. Sometimes skin can be wax pallid color, which is characteristic for amyloidosis and systemic diseases, lipoid nephrosis. Skin of the patient may be covered with scratches as a result of skin itching for the patient with renal failure. We examine tongue of the patient, especially if the patient complains of dryness in mouth. Coated dry tongue is characteristic for renal insufficiency. And in progressive renal insufficiency, I said you from the patient, especially from the mouth and skin, will be specific unpleasant odor of ammonia, which is called phytouremicus, which is characteristic for progressive renal insufficiency. You see scratches on the skin due to severe skin itching, and on local inspection, examination of lumbar region, sometimes we can see reddish and protrusion of this area. If we'll touch, it may be hot, which is result of paranephritis, inflammation of extrarenal cellular tissue. Palpation. Usually kidney impalpable. Methodic of palpation you will study on practical classes, as liver kidney palpate with bimanual method, both hand, but on contrary from other organs will palpate kidney both horizontal and erect position to distinguish enlarged and movable kidney. Kidney palpable in new growth, in amyloidosis, tuberculosis, hydronephrosis, and nephroptosis. If the kidney palpable, to differentiate some pathology, will pay attention on its shape, size, surface, tenderness, mobility, and consistency. I'll again remember you, health, kidney impalpable. You see normally right kidney slightly lower, if we'll see left kidney lower, it is nephroptosis. If the right kidney significantly lower, it's also nephroptosis. Now, if kidney impalpable, we can reveal its pathology with palpation of painful point due to crossing innervation. We distinguish two groups of points: tenderness points for kidney and for ureter. Kidney points localizes along external edge of abdominal rectus muscles along its external edge on the level of 12th rib. Will palpate right and left side separately. In front and then at the back also level of 12th rib, but along external edge musculus latissimus dorsi. Two kidney points in front or at the back on the level of 12th rib. Two ureter points, fourth group on the level of navel along external edge of rectus muscle, and on the crossing it with iliac inguinal bone. Two groups of kidney and two groups of ureter point. On percussion will determine response of the kidney on tapping movement. Paternatsky symptoms will tap over the kidney. I'll pay your attention through the hand and on the level of 12th rib, not anywhere as you do on exam. If the patient feels discomfort or pain, we are talking about positive Paternatsky symptom, which is characteristic for pyelonephritis and nephrolithiasis. Laboratory method examination. No, first of all, urinalysis, which is routine method examination, which is obligatory for everybody. Specific test, Nechiparenko test, will prescribe only for differential diagnosis between pyelo and glomerulonephritis. Zimnitsky and Reberg test will use for diagnosis of renal insufficiency. Instrumental examination. First of all, X-ray and ultrasonography. Ultrasonography more widely used because it's non-invasive method without any complication and not needed specific preparing. X-ray examination restricted because it's impossible in high level of creatinine, otherwise progressive renal failure, and for patient with some allergic reaction. Same restriction for radioisotopic method. Computer tomography is needed in case of new growth or some specific pathology which difficulty revealed on ultrasonography. And needle biopsy, which is final stage with definite indication. On X-ray examination, due to action of contrast, we can see kidney, assess its structure, pelvis, ureter, and reveal some pathological process. You see widening of pelvis and obstruction of ureter. Renal angiography is used only in definite case patient with grave uncontrolled arterial hypertension because it helps assess renal arteries to reveal its narrowing or stenosis of renal artery, which is provoked fractures of renal hypertension, and in this case any therapeutic measures non-effective, patient needed only surgical correction. Ultrasonography easy reveals presence of stone because we see specific spots with acoustic wave. Radioisotopic method helps assess functional activity of the kidney and its structure in diagnosis of new growth or inflammatory process. And these graphs show activity releasing of radioisotope to characterize renal functional activity. Computer tomography together with kidney assess all surrounding organs. You see new growth into the kidney and increase its size. And I said you needle biopsy only with definite purpose because it's invasive method with some complication. But in some pathology, only histological examination helps clear true disease and give more correct treatment, especially in new growth. Next questions on which I want to stop today, there are Raynaud syndrome because you know principles of our diagnosis from symptom to syndromes and to disease. And I'll remember you, syndrome is complex of pathological symptoms which combine with same etiologic mechanism. We'll stop on diagnosis of the next syndromes: edematous, nephrotic, hypertensive, renal colic, renal eclampsia, and renal insufficiency. Renal colic, I gave you specific characteristic of pain, which is main pathological symptoms with pay attention of doctor on possible disease. I not stop again. For diagnosis, we'll use X-ray examination, which helps reveal stone, or ultrasound examination, obligatory urinalysis, which is characterized with hematuria, and combination of this result helps clear disease nephrolithiasis. Edematous syndrome. Edema characterized with keeping liquid inside the body with different mechanism. Edema is revealed in a thinning patient and more difficulty of the patient with obesity. To control or reveal edematous syndrome, we'll use next procedures. First of all, we'll control weight of the patient, especially if we'll give diuretic medicines. We'll control daily diuresis, obligatory dependent water balance. Patient must calculate amount intake liquid and excreted urine. And sometimes we needed special test, McClure-Aldrich test, when we'll introduce in subcutaneous injection 1 milliliter of isotonic solution and control time of its resolution. Usually it must be removed during 1 hour. If early, it indicates predilection of patient to edema. Mechanism formation of edema. We distinguish four main mechanism formation of edema. First of all, due to diffuse increased permeability of the capillary wall, when the plasma easily absorbs in surrounding tissue. Other way, it is colloidal osmotic mechanism. Other word, hypoproteinemic, when the no oncotic pressure which hold liquid inside the vessel. Hypernatremic edema, when the level of sodium inside the body increase and due to regulation, liquid go outside from vessel and hold inside the body. And anuria, acute anuria. You understand? No urination, on liquid hold inside the body. Let's see what mechanism is more characteristic for kidney diseases. First, diffuse increased permeability of the capillary wall, more characteristic for allergic and systemic edema. No, I seen you listen about quincus edema, when the edema first of all localizes on the face near the lips, then go downward and may be complicated with complete obstruction of upper respiratory way. You understand why if it needed emergency aid. Hypoproteinemic edema is characteristic for patients with nephrotic syndrome because loss of protein not correlated with its synthesis. It may be result of hunger, which start from the lower extremities, first of all from solid. It is characteristic for malabsorption, when the protein cannot be absorbed and intake in metabolic process, and for canceromatose process, because due to new growth will be disturbed protein metabolism. Hypernatremic edema is characteristic for the patient with pyelonephritis and heart failure. Such edema is released with diuretic medicine, on contrary from hypoproteinemic edema, which cannot be released before correction of albumin, before normalization of oncotic pressure. And acute anuria is characteristic for the patient with acute poisoning, with terminal stage of some chronic renal disease, and for profuse bleeding, shock, and any other pathology about which we said about when we said about secretory anuria. Nephrotic syndrome. syndrome which is characterized due to disturbed protein and fat metabolism. It is characteristic for the patient with chronic glomerulonephritis, but it may be in any other pathology which is characterized with involvement protein and fat metabolism. It is infectious disease, malaria, sepsis, tuberculosis. It is systemic disease, collagenoses, and metabolic disorders, diabetes mellitus. But for kidney nephrotic syndrome, it's characteristic for the patient with chronic glomerulonephritis. I said you, disordered protein and fat metabolism. Clinically, it's manifested with persistent edema, persistent, which cannot be released with usual diuretic medicines. Why? Because no oncotic pressure. Organism progressively loses protein with urine, proteinuria, as a result, low level protein in blood, proteinemia, and disordered fat metabolism, which is characterized with hyperlipidemia and, first of all, hypercholesterolemia. Other word. If you see patient with severe persistent edema which not responds on your diuretic treatment, will control protein in blood, cholesterol in blood, and examine urinalysis. And if you reveal hypoproteinemia, first of all hypoalbuminemia, hypercholesterolemia, and analysis of urine is characterized with proteinuria. As result will be high specific gravity and urine rich with casts, which indicates about nephrotic syndrome. Usually, which is characterized with progressive decreased diuresis and accompanied renal failure. Hypertensive syndrome. I said you, clinically it's not different from any other hypertension. Patient complaints of headache will reveal high blood pressure. On auscultation of the heart, accent second sound over aorta. Later will be different problem with heart, but specific signs is early renal retinopathy, which revealed due to examination fundus oculis. And it is characterized with specific salus symptoms. We distinguish on 3 degrees. I want that you understand. Salus symptom is characterized with progressive narrowing of arteries and dilation of veins on fundus oculis. As a result, due to narrowing of arteries will be disordered blood circulation, disordered nutrition of retina. We see dystrophic spots. Due to rupture of dilated vein, we can see hemorrhagic spots. And then more progressive process, then early patient loses vision. First degree salus symptom is characterized with stenosis of arteries, tortuosity of the veins, and flatness of the veins at the crossing with arteries, with formation of ampoule-like dilation, because arteries push on the dilated vein, with simulation of ampoule-like dilation. Second degree salus symptoms becomes more progressive. Arteries lumen significantly narrowed. The course becomes tortuous. Vein, due to compression of the artery, simulate rupture. And final, third stage salus symptoms. Arteria touch significantly narrowed. Blood flow through it such significantly restricted that they resemble silver white, except red color health specific silver like color. When such significantly depressed into the retina, that simulate rupture because some part of the vein becomes unvisible. No, as a result, I explained you, we reveal dystrophic and hemorrhagic spots and affection of papilla of the optic nerve. You see fundus oculi in final period, unvisible arteries because severe narrowing, simulation of the ruptured vein in its crossing with arteries and hemorrhagic spots. Health fundus oculi and affected fundus oculi, unvisible arteries like ruptured ample dilated vein and dystrophic spots, which very poor with blood circulation. Renal eclampsia is specific syndrome which appears due to increased intracranial pressure. It is characteristic for acute diffuse glomerulonephritis, which aggravated chronic glomerulonephritis, and as manifestation later pregnancy nephropathy, especially for the woman with pathology of kidney in anamnesis. If we'll stop on pathogenic mechanism formation of renal eclampsia, I said you it is syndrome which appears due to increased intracranial pressure, edema of cerebral tissue and cerebral angiospasm. As pathological response of central nervous system on any pathological process, we see specific convulsions, which is main clinical signs of renal eclampsia. Provoke factors are pronounced edema and uncontrolled increased blood pressure. Patient come to you with severe headache, with severe edema. You prescribe some medicine, they not completely effective. You give the patient specific dietary recommendation. First of all, patient restrict water and completely exclude salt from diet. If the patient not go to your recommendation, edema progresses, pressure increases, and as a result, systemic blood pressure finish with increased intracranial pressure, edema of cerebral tissue due to cerebral angiopathy, and specific convulsions. First signs of approaching eclampsia which can be stopped. Patient feels unusual somnolence and flaccidity. We see his vital activity decreases. He complains of severe headache which accompanied with vomiting. Patient periodically loses vision, amaurosis, cannot talk, loses speech, aphasia, feels transient paralysis or parathepia, and some mental confusion. And if the patient again not go to your dietary recommendation and treatment recommendation, then blood pressure significantly increased, edema progressively increased, and finish with increased intracranial pressure. Patient falls, we see convulsions which develop unexpectedly, sometimes after uttering cry or after noisy deep inhalation. We see a patient suddenly deeply inhale and falls. And we see strong tonic spasm of peripheral muscles, which then transformed in clonic contraction of peripheral muscles, less frequently only twitching of some muscles. Usually, convulsions resembles attacks of epilepsy, and first of all, patient may be assessed as epileptic patient. Because clinically patient falls, his face becomes cyanotic, we can see swelling of neck veins, eyes turn aside or roll up, sometimes maybe bitten off tongue. We can see foam emerges from the mouth, pupils dilated and don't respond to light, eyeballs foam during touching, pulse is tense and slow, arterial pressure high, convulsion accompanied with involuntary defecation and urination. Attacks of renal eclampsia last for a few minutes, then disappear, but sometimes patient can be in deep sopor or coma. Then through the stupor, his consciousness come back to normal. But during recovery period, maybe some problem with vision, amaurosis, and with speech aphasia. I said you, we see attacks of convulsion, eclampsia. It must be differentiated from epilepsy, and if you remember last practical class, from Margagnier-Adams-Stokes syndrome, which is characteristic for progressive atrioventricular block. How can be differentiated? Epilepsy is specific psychic disorder. Normal blood pressure, normal pulse rate. Margagnier-Adams-Stokes progressive atrioventricular block. Sometimes no pulse and pressure or very low pulse rate. Eclampsia, high blood pressure, because progressive hypertension is provoked factors of increased intracranial pressure. But if the basic characteristic of eclampsia increased intracranial pressure, which is differential diagnosis indices for differential eclampsia from epilepsy and Margagnier-Adams-Stokes. Basic pathogenic mechanism eclampsia is increased intracranial pressure. Principles of emergency aid is decreased intracranial pressure and latent cerebral edema, which is possible due to puncture of spinal cord, but you understand this manipulation needed specific practical skills. If doctor unable, Other method, intravenous injection, magnesium sulfate. Intravenous. You study characteristic of these medicines on pharmacology. No, if no, we'll study and you will know that magnesium sulfate, depending on way, is characterized with different action. If we'll give magnesium sulfate per oath, it acts as laxative medicine. Intramuscular, it helps regulate systemic blood pressure, and only intravenous injection decrease intracranial pressure. And last syndrome on which we'll talk today, which is renal failure, which is characterized with disturbed renal function. It may be acute or chronic. Acute uremia appears due to acute situation about which we said today. Chronic uremia is result any chronic kidney diseases. And first of all, diseases which affect both kidney, which is glomerulonephritis, progressive nephrosclerosis, then chronic pyelonephritis and new growth. I'll stop on all the development of acute and chronic uremia because they are different. Renal failure appears due to progressive death of nephrons, main active units of kidney. As a result, will be structural and functional compensatory changing of the remaining nephrons. I said you, one healthy kidney long time can compensate affected, and patients sometimes can live and unknown about problem. But especially when the both kidney involved in pathological process, functional kidney reserve progressively decreases. As a result, in blood accumulated protein decomposition substances. There are nitrogen, there are sulfur compound, aromatic substances, which manifested with increased level of nitrogen, creatinine, and urea, blood urea. As a result, will be changed pH in our organism from neutral or light alkaline, it's become acidic. Process accompanied with electrolyte imbalance. As a result, affection of the organs due to progressive metabolic disorders, and finally uremia. It is final stage of renal failure. Now let's stop on all the development of acute renal failure, which appears due to some acute situation. An initial stage may be invisible. Then second progressive stage, which characterized with progressive decreased diuresis, oligoanuric period. If process positive, patient can go to other polyuric stage and long recovery stage, long recovery period. Initial stage, invisible, because doctor pay attention on main pathology. Patient with severe trauma, with post-traumatic shock, with some progressive severe infectious diseases, with poisoning enters in hospital. And all attention of doctor on main disease. But in any grave situation, will obligatory control vital activity of all vital organ, and kidney activity will control depending on, first of all, amount of urine. And if the kidney involved in pathological process after some hours or during first week, patient will go to other second stage. And if patient consciousness, he can say about progressive decrease of urine. If unconscious, doctor will see that diuresis of the patient progressively decreases, first of all negative, then oliguria when less than half liter per day, and complete anuria. You understand? Due to decreased urination will be progressive intoxication and water electrolyte disorders. Patient complaints of vomiting or VC vomiting, we see mental confusion, we see problem with respiration and cardiovascular system, blood pressure increases, appears edema. If present urination will control urinaries and reveal pathological elements, erythrocyte, protein, CAS, will control blood analysis and first of all urea and creatinine, and count glomerular filtration rate. We can count glomerular filtration rate with special formula only due to blood creatinine, or if present urination, we can use Reberg test and determine glomerular filtration rate and coefficient of reabsorption depending formula as result of blood and urine creatinine. But more often last time we'll use formula only with blood creatinine to count glomerular filtration rate because it's main index of renal failure. Our action only hemodialysis, and you must know that apparatus for acute and chronic hemodialysis are different. If the manipulation effective and will remove intoxication, patient will go to next third stage. If no, we lose the patient die due to intoxication. We'll go to effective positive process, and from second stage patient go to third stage. How can you know about it? From anuria, patient again starts urinate, but not normally, polyuric period, because affected kidney cannot control diuresis. It suddenly and significantly increases. As a result, intoxication decreases, concentration of residual protein substances in blood decreases, will be restored water electrolyte balance, will be released edema and control blood pressure, progress, then will be come back diuresis. From polyuria it becomes nearly the norm, but specific gravity of urine long time will be low, and we cannot say about complete halting. Patient go in the final fourth recovery stage, which can last from 3 to 12 months. Will wait normalization of specific gravity. Patient will be discharged from the hospital with normalization of diuresis but low specific gravity, and will wait normalization of specific gravity 1 year. If no, acute renal failure transformed in chronic renal failure and chronic kidney disease. Chronic renal failure appears as result progressive long-standing chronic disease. It's also divided on some stage And I'll weigh your attention. Any chronic failure divided on 3 periods. Initial, unvisible, which may be reviewed only with specific method. Manifested, visible. For chronic renal failure, it divided on 2 substages. First of all, polyuric, then oligoanuric. Opposite way, on contrary, from acute renal failure. And finish with terminal period, decompensated period, when in pathological process involved other organs. Remember, please, same principles for classification chronic failure for any organ. Initial, unvisible, manifested because visible, and final, terminal, due to involvement other organs. Diagnosis of chronic renal failure. Initial period, unvisible. Patient hasn't any other problem depending of main diseases. And only special laboratory test control creatinine and glomerular filtration rate helps reveal early period of renal failure and intensified our treatment. Anemia may be initial signs of renal dysfunction because you remember activity of kidney in hematopoiesis, erythropoietin. We can pay attention on low specific gravity of urine, which below 1.017 in repeated analysis. And I'll again pay your attention on the level of creatinine and glomerular filtration rate. We'll count creatinine of blood and with special formula count glomerular filtration rate. There are main principle diagnosis initial period because it's unvisible. Manifested subcompensated period. When the functional activity nephrons becomes less than 70%. Organism lost 30% of active nephrons. Process becomes visible. And first of all, patient complains on weakness, progressive weakness, on uncontrolled blood pressure, on progressive edema, and we can see the skin of the patient pale because progressive anemia and spasm of peripheral vessels due to increased blood pressure. We see edema, which very difficult to respond with unusual treatment. We'll pay attention of the patient on diuresis, and he can say that diuresis decreases, or we can reveal it with special test, Zimnitsky test, and all laboratory indices progressively deviate from norm. Final decompensated period, characterized with involvement of other organs and system. Why we are talking about decompensation? Because except one organ, kidney in our case, will be involved other organs. And first of all, skin, because I said you, if urea cannot be removed with urine, it's removed through the skin. Skin becomes specific icteric tint due to involvement of liver and kidney tightly connected due to common detoxicated function. Skin becomes dry because urea absorbed through the skin, and sometimes will be illusion of powder skin. We see urea crystals on the skin. It's manifested with severe skin itching. Doctor sees scratches on the skin. And we can see hemorrhagic rashes on the skin due to involvement of vessels and increased permeability of peripheral vessels. Urea will be removed through the mucosa, and first of all, mucosa of respiratory and digestive system. Respiratory system mucosa. First of all, specific unpleasant uremic breath. If the urea passes through the mucosa, it becomes dry. Respiratory tract losses its immune response. Patient predilected to laryngitis, bronchitis, then pneumonia and other inflamed pathology. Urea absorbed through the mucus of digestive system. It's complicated with uremic gastritis. Patient complains of nausea and vomiting after eating. Uremic colitis. Patient predilected to diarrhea, which difficulty control with usual medicine. And finally, gastrointestinal tract, predilected to ulcerous and necrotic affection with different bleeding, bloody vomiting, bloody defecation. Liver, first period, compensate detoxicated function of the kidney are then affected also, and skin of the patient becomes more yellow color. Central nervous system very sensitive to any intoxication. And affection of and cardiovascular system, first of all, due to high blood pressure. Overloading of the heart. Then due to absorption of urea, uremic pericarditis, disordered electrolyte metabolism, different arrhythmia, and as a result, congestive heart failure and more grave, which is myocardial infarction and brain stroke and loss of vision, a grave complication of high blood pressure. Central nervous system, first of all, inversion of sleep apneic syndrome, then uremic encephalopathy and polyneuropathy due to disordered electrolyte and vitamin metabolism. And terminal period, manifested with complete anuria, as a result, progressive intoxication, patient loses consciousness, and patient needed for continuous hemodialysis, but it must be prescribed before anuria in oligouric period. And next, kidney transplantation. If we lost time, we see patient with uremia. From patient will be specific uremic breath. We can see that his skin covered with different skin hemorrhage. We can see different bleeding, which difficulty stop due to heavy hyperhydration, progressive edema, anasarca, edema spread on all inner tissue, pulmonary edema, brain edema, critical hyperkalemia, and uremic coma, which manifested with death of patient. Helpless of our patient, only hemodialysis with next kidney transplantation, no any other way if the both kidney progressively decreases. No, that's all material which I want to show you today. Thank you for your attention. Goodbye, be healthy, and all questions which will clear during practical classes. Thank you so much for your attention.